Hi everyone, and welcome to Diagnosis Bona, Curatio Bona. And so we continue our endocrinology playlist, and today we will talk about thyroid diseases. So we will talk about hypothyroidism or myxedema, hyperthyroidism or thyrotoxicosis. Also, we will talk about thyroid nodules and thyroid carcinoma. So let's get started. Hypothyroidism or myxedema, and so let's first talk about patients who is at risk. So patients at risk include those with previous grave disease, autoimmune disorders like rheumatoid arthritis, or for example type 1 diabetes, and actually up to 5% of patients with insulin-dependent diabetes eventually develop autoimmune thyroiditis. And Down syndrome, Turner syndrome, also drug treatment, lithium, amiodarone, interferon, previous thyroid or neck surgery, and previous radioactive iodine treatment of the thyroid. And clinical features are constipation, cold intolerance, tiredness, lethargy, somnolence, physical slowing, mental slowing, depression, huskiness of voice, puffiness of face and eyes, pallor, loss of hair, and weight gain. Also, it could be amenorrhea due to changes in gonadotropin-releasing hormone production. On physical examination, sinus bradycardia, delayed reflexes, coarse, dry and brittle hair, thinning of outer third of eyebrows, dry, cool skin, skin pallor or yellowing, obesity and goiter. Okay, and let's talk about Hashimoto's thyroiditis. It's an autoimmune disorder of the thyroid gland and associated with hypothyroidism, but also could be transient thyrotoxicosis in acute phase. So symptoms bilateral goiter, which is firm and rubbery, so it's not tender. Diagnosis: TSH elevated and T4 subnormal, and positive anti-thyroid antibodies test. Serum cholesterol level elevated, anemia, usually normocytic, maybe macrocytic, ECG, sinus bradycardia, low voltage, and flat T waves. Okay, so we talked about hypothyroidism when TSH quite high and T4 is low, and also there is a condition which called subclinical hypothyroidism when there is a raised TSH and T3 and T4 is normal range. So, and it's quite questionable condition because it's not clear should be these patients treated or not. Risk of progressing to overt hypothyroidism is 2 to 5 per year, and risk increased by presence of thyroid antibodies. And another condition when if T4 and T3 is low and TSH is low or normal, it could be pituitary dysfunction, so it's a secondary hypothyroidism, or sick euthyroid syndrome. So management is thyroxine, and after prescribing this treatment you have to monitor thyroid function tests. It's between 4 to 6 weeks after the start of treatment. And I also wanted to say one thing. Patients with a long-standing history of Hashimoto thyroiditis, and they are at 60s. They have increased risk of lymphoma of thyroid, which is most often non-Hodgkin lymphoma. Next condition is neonatal hypothyroidism, and it's very important to diagnose it early because it can lead to permanent intellectual disability. And clinical features are supraorbital edema, dry skin, coarse body features, harshy cry, jaundice, slow feeding, and umbilical hernia. And thyroxine replacement should be started as soon as possible after the diagnosis, and ideally with 2 weeks after birth. And women have to take thyroxine when they planning to conceive, and also increase their dose of thyroxine by 30% at the confirmation of the pregnancy. And also TSH should be monitored every 8 to 10 weeks during pregnancy when further dose adjustment is necessary. Thyroxine dose requirement returns to the pre-pregnant level after delivery, and it doesn't matter is this mother breastfeed or not. So, and causes of hyperthyroidism or thyrotoxicosis, grave disease. So, and typical symptoms of grave disease, it's a diffuse goiter and eye signs, autoimmune functioning nodules, toxic adenoma, subacute thyroiditis, or the Currarine thyroiditis. It has viral origin, and patients have symptoms like painful thyroid and malaise. Excessive intake of thyroid hormones or thyrotoxicosis fastigia, exogenous iodine excess if there is some food contamination, amiodarone, and struma avari. And clinical features: heat intolerance, sweating of hands, muscle weakness, weight loss despite normal or increased appetite, emotional lability, especially anxiety, irritability, palpitations, and frequent lost bowel motions. On physical examination, you can see agitated, restless patient, warm and sweaty hands, fine tremor, and goiter, proximal myopathy, hyperactive reflexes, bounding peripheral pulse, and it could be atrial fibrillation. And it's quite rare, could be chronic periarthritis and calcific tendinitis. Diagnosis: so it's TSH is low, so its level suppressed, and T4 and T3 elevated. To differentiate all these different conditions which lead to hypothyroidism, there is a very good test, and it's called radioactive iodine uptake scan. And if the radioactive iodine uptake scan reveals diffuse iodine uptake, then it's Graves' disease or toxic multinodular goiter. If RIO scan reveals focal iodine uptake, it's likely a functioning adenoma. If the RIO scan reveals no iodine uptake, so you have to suspect thyroid carcinoma. So, and serum thyroglobulin measurements have to be the next step. And also you have to suspect struma avari or thyrotoxicosis fastigia. Treatment: radioactive iodine therapy, thiamide antithyroid drugs, carbimazole or propylthiouracil, or methimazole. Surgery: subtotal thyroidectomy or total thyroidectomy. Let's discuss some side effects of this treatment. Radioactive iodine therapy can worsen Graves' ophthalmopathy. Agranulocytosis is a side effect of antithyroid drugs, and recurrent laryngeal nerve injury can occur in surgical thyroidectomy. Graves' disease. It's an autoimmune disorder, commonly presents in women aged 40 to 50 years, and symptoms: goiter, exophthalmos, and peritibial myxedema. Diagnosis: it's positive TSH receptor antibodies and normal or elevated diffuse uptake pattern on radionuclide thyroid scan, and TSH is very low and T3 and T4 are elevated. Treatment: younger patients with small goiter and mild case, they can just take antithyroid drugs. Larger goiter or moderate to severe cases, antithyroid drugs until euthyroid, then surgery or radioactive iodine therapy. Subacute thyroiditis and is usually transient and follows a surge of thyroxine after a viral type illnesses. And diagnosis it will be low TSH and normal T3 and T4. Symptoms: pain and tenderness over the goiter, especially on swallowing, and fever. In the acute phase, treatment is based on rest, analgesics, so it could be aspirin or ibuprofen, and soft food. Also is needed corticosteroids and beta blockers. Thyroid crisis or thyroid storm. Clinical features: anxiety, weight loss, weakness, proximal muscle weakness, hyperparexia, tachycardia, heart failure, and arrhythmias. So treatment this very threatening condition is antithyroid drugs, IV saline infusion, IV corticosteroids, anti-heart failure and anti-arrhythmias therapy, especially beta blockers. Thyroid nodules. They are solid or fluid-filled lumps and bumps. Causes: dominant nodule in a multinodular goiter, colloid cyst, true solitary nodule, adenoma, carcinoma. And diagnosis: it's a fine needle aspiration cytology, thyroid function tests, ultrasound, thyroid carcinoma. Risk factors for developing thyroid cancer include family history of benign thyroid disease, radiation treatment to the neck area at a young age, family history of thyroid cancer, familial adenomatous polyposis, and chronic goiter. The main presentations are a painless nodule, a hard nodule in an enlarged gland, or lymphadenopathy. So it's usually an enlarged cervical node. Diagnosis: serum thyroglobulin measurements, also iodine thallium scanning and neck ultrasound. Fine needle aspiration and treatment: total thyroidectomy, ablative iodine treatment, and thyroxine replacement. And now let's talk about different kinds or different types of thyroid cancer. Papillary thyroid cancer is the most common type and the least aggressive. It spreads via lymphatics. Follicular thyroid cancer, also known for its vascular capsular invasion and hematogenous spread. Medulla thyroid cancer is seen in the Man-2 syndromes and arises from parafollicular cells. Calcitonin is a tumor marker, and the cancer spreads via lymphatics. Anaplastic thyroid cancer. It's a rare type, making up to 2% of thyroid cancer cases, and one of the fastest growing and most aggressive of all cancers. And it's also known as undifferentiated thyroid cancer. So thank you very much for watching, and see you next time. Bye bye.